Let's talk about cerebral vascular accident. But first, what is a cerebral vascular accident? Well, it's an interruption of blood flow to part of the brain. Without normal blood flow, the affected area is deprived of oxygen and cell death begins to occur in as little as 4 minutes. The effects of oxygen deprivation vary depending on the area of the brain involved and the length of time the brain is deprived of oxygen. So getting help, seeking help during this time is of utmost importance. Stroke is the 5th leading cause of death and the leading cause of adult disability in the United States. There is more than $60 billion spent each year on treatment, medications, and missed work, as well as rehabilitation. But we still have hope that we can conquer this. And the way we have hope is by knowledge. Knowledge is power. So we want to know about the signs and symptoms of impending stroke, or TIA. We want to prevent the stroke. We want to tell our family members how to prevent stroke. We want to be exemplary of how to live a healthy lifestyle and be a leader in that. So let's look and turn the page to page 398, and we are going to look at risk factors. Now there's modifiable and non-modifiable. Non-modifiable factors we have no control over. They cannot be changed. Age, can't change it. Race, gender, and heredity. Modifiable factors, we do have some control. So let's look at table 23.1, and what is listed number 1? Hypertension. That's really important to remember because that is the number 1 cause and the number 1 risk factor. So antihypertensive drugs, weight control, stress management, smoking cessation, limited alcohol, low-fat diet, those are all things that can be controlled. Also, CVAs are more common in men, African Americans, people 51 to 74 years of age, and those with a family history of CVA. So what is a TIA? A TIA is a temporary neurologic deficit caused by impairment of cerebral blood flow. Blood vessels occluded by spasms, fragments of plaque, or blood clots. A lot of times this will be coming from the carotid artery. Maybe there's a plaque in the carotid and when you turn your head, that carotid might be occluded. And if the other carotid artery has a plaque and you're not getting any blood flow, you could have a TIA. So important warning signs for the individual experiencing the full stroke. But what is the TIA warning signs? Well, it could be just dizziness, momentary confusion, loss of speech, loss of balance, tendinitis, visual disturbances, dysphagia, drooping mouth, drooping eye. I saw my mother, one whole side of her face just began to melt. The eye drooped, the mouth drooped, and then she had some trouble speaking. So luckily, I was able to get her help quickly, and that was resolved. So those are some signs and symptoms. Medical diagnosis is usually made with CT, MRI, but I'll tell you that by the time a patient gets to the hospital and gets the CT scan or the MRI, they may not see anything. A lot of times it doesn't even show up for a couple of days. So they'll go, and even though they had the symptoms and the warning signs, then they have the MRI and there's nothing there. So they think, oh, I'm fine, and then they go home. But most doctors are aware that that's what happens, so they put them on some anticoagulants if it was embolic stroke, depending on their symptoms. So what is the treatment? Depends on the cause, the carotid artery disease from atherosclerosis, And we could possibly do a carotid endarterectomy. We used to call that like a roto-rooter. They just go in and clean out that carotid artery of plaque and clots, anything that was building up there that stopped the blood flow to the brain. Initial treatment is usually aspirin alone or in combination with Agranox. And there are some medications listed on Table 23.2. It does talk about some other medications, and I will be talking about some as well. In fact, prevention, so aspirin and Agranox are blood thinners, right? Prevention is to prevent new clots from forming, and that's what heparin and Coumadin does. Now, Coumadin you can take orally, right? You have to have your blood watched, your INR observed every month. Heparin is sub-Q. So if you want to go home on sub-Q, they have done that. But it's not really the way to go home. It is good initial treatment, however. So this is just a picture I have here of the carotid artery and how they do a repair or an endarterectomy. So this is, there's two pictures on page 402. I took the first picture, the second picture actually, that was so that you could see all the internal workings. Very interesting. Plaques are removed from the artery here to improve blood flow. And this is not that bad of a surgery. It's usually like just a couple days in the hospital. So, but you do have a scar on the side of the neck. So, stroke. So a stroke is an abrupt impairment of brain function resulting in a set of neurological signs and symptoms caused by that impaired blood flow to the brain, and it lasts more than 24 hours. So a TIA is shorter acting, and a stroke, these symptoms last for more than 24 hours. Now, when symptoms progress over hours or days, the condition described as stroke in evolution. That's important to remember, that stroke in evolution could mean that it's just evolving. Symptoms, a little bit of symptoms every day. Signs and symptoms for the patient having a stroke, they would complain of the worst headache of their life. The medical diagnosis can be made by CT, MRI, lumbar puncture. They do a lumbar puncture if they don't suspect a hemorrhagic stroke, or if they do expect a hemorrhagic stroke, because they'll do the lumbar puncture and they'll get blood, and then they'll know that it was hemorrhagic. Complications occur, can be many. We'll talk about those in just a second. So the prognosis depends on conditions before the stroke, the condition of the patient before the stroke, their diagnosis, the treatment and support in the acute phase during the first 48 hours. So this is just a picture of an embolic stroke on the left, and how it's just a clot or a plaque. Hemorrhagic strokes actually are bleeds in the brain. And remember from other lectures, there isn't a whole heck of a lot of room in your skull for anything that doesn't belong there. Blood leaking out puts pressure on the areas of the brain, and there just isn't room for a lot of blood. Okay, I'm trouble turning the pages. So this is just to show you about right brain, left brain damages. So the right side of your brain affects the left side of your body. The left side of the brain, if the damage on the left side, it's going to affect the right side of your body. So you can look through that and see the different deficits from right and left brain damage. So what are some neurologic deficits that you might get? So aphasia. Aphasia is a defect in use of language. It can be expressive or receptive. Now, receptive means that difficulty understanding words. So if you gave a command to a patient, they might not understand what you're saying. Expressive is they have difficulty speaking and writing, expressing themselves. So a difference between expressive and receptive. Receptive, they cannot receive the information. Now, dysarthria is an inability to speak clearly. I guess that's me. Dysarthric patients are difficult to understand, but they understand what is said and have no difficulty putting that information together. Then there is dysphagia. We know that one. That's difficulty swallowing. Dyspraxia, they can move affected parts but not purposeful. So they can move their arm but they can't reach for what they want to reach for. Hemiplegia is paralysis of one side of the body. Sensory impairment. Now with sensory impairment, it puts them at risk for injury because they can't feel. They can't feel that side of the body. They don't know if their leg is through the rails of the bed. They don't know if their hand is moved backwards and they're hurting their wrist or fingers. So really be careful in positioning your patients and be sure that, especially patients that can move their body parts but they aren't purposeful, they could get rolled over on their body and hurt themselves. Unilateral neglect means that they neglect part of their body. So if it's on the right brain, they're going to neglect the left side of their body. Hemaniopsia is the loss of vision in one side. And they can have elimination disturbances. So what are some diagnostic tests and procedures that can be done? So blood studies. So what would you do? Well, you might do CMP, check for some inflammation, ECG, CT scan, MRI, carotid ultrasound, cerebral and carotid angiograms, a PET scan. If the CT is negative for blood, the lumbar puncture might be done to examine the CSF. If it's bloody, that is indicative of a hemorrhagic stroke. And in that case, anticoagulants are contraindicated. So a lot of times they do a lumbar puncture right away. They'll check the carotids. That's a really easy thing to do. They can do a carotid ultrasound. Usually you can get that done the minute a patient comes in the middle of the night. Of course, you know that's always when things happen. But if they do a lumbar puncture, they can find out how do they treat this patient. If it's a blood hemorrhagic stroke, that one kind of treatment is going to be done. They're not going to put them on a blood thinner, are they? So that's why sometimes a CSF or the lumbar puncture is important to do. So in acute phase, that begins with the onset of signs and symptoms and continues until vital signs, particularly the blood pressure and neurologic condition, their LOC, is stabilized. So it's a challenge for the doctor to provide care for these problems because they also have to take care of the pre-existing conditions if they had that. And so what are the 4 major focus areas in treating a patient suffering from a stroke? So the focus areas are hypertension. So be aware of hypoperfusion of the brain. Oxygenation. Monitor their O2 saturation for less than 94%. It's a little higher here. I know we usually talk about 92%, but we're talking about oxygen, air to the brain. Hyperthermia, the stress response can make them have a fever, as well as hyperglycemia can also be a stress response. They're they're not diabetic, but they have high glucose, and that is the body's stress response. So let's talk about some drug therapies. So drug therapy, the TPA. So I want you to turn to page 407, and I want you to note the inclusion criteria because it's very limited who is a candidate for TPA or tissue plasminogen activator. So age 18 years or older, these are inclusion criteria. Diagnosis of ischemic stroke causing measurable neurologic defect. Clinical diagnosis of stroke with the NIHS score less than 22. And time of onset of stroke is known and is 3 hours or less. So from the moment that they have symptoms, 3 hours is the time limit. Then you can read through there and see the exclusion criteria. It can be things like subarachnoid hemorrhage, intracranial hemorrhage, recent surgeries, and then there's some relative exclusion criteria as well. So some medications that can be used would be mannitol, and if you remember, mannitol is for cerebral edema, decreases the edema, the swelling in the brain, decreases the pressure on the centers in the brain, and hopefully they won't have any long-lasting symptoms. Another drug that's important to know is nimodipine or pine or Nimotop. It's a calcium channel blocker. Remember I said pine because if you've watched that YouTube about the pine drugs, it's like a pine tree blocking the channel or the river. So it's a calcium channel blocker, and that prevents spasms of cerebral blood vessels. Dilantin or phenytoin and phenobarbital prevent seizures because anytime there's an irritation in the brain, blood, swelling, it can cause seizures. Another treatment is acetylsalicylic acid or aspirin, ticlopidine, hydrochloride or Ticlid, Agrinox, and Plavix. Surgical intervention, of course, that depends on the location of the stroke. Fluids and nutrition, they need to be NPO if they're going to have surgery. There needs to be a good IV access, and they need to have TPN if they're malnourished. That gives them enough energy and enough nourishment to fight off the battle, getting back to functioning. Now, urine elimination. Sometimes indwelling catheters used to manage urinary incontinence, or intermittent catheterization is a method of controlling incontinence caused by a flaccid bladder, and that can occur with stroke. Intermittent catheterization is done every 4 to 6 hours as ordered. And you can use a bedside ultrasound. Have you ever used one of those? Those are pretty cool. You just put that over the abdomen and you can see the yellow areas. It looks like a little island in the abdomen, and you know how much urine is in the bladder. Actually, the machine can tell you how much it's detecting. And then you'll know if you need to catheterize or not. And along with the fluids and nutrition, always remember intake and output. You want to know what goes in comes out, right? So if they're getting IV fluids, 150 cc's an hour, mLs an hour, it's got to come out, or they're going to get distended, uncomfortable, and as we see, that can cause some problems. So monitor their urine elimination, I&O. All right, now we're going to get to another part, but I want you to notice while we're on page 408, there's a great nursing care plan about a patient with a stroke. It talks about a 78-year-old male admitted with weakness on the right side and slurred speech. So I want you to read about that. And under adequate nutrition related to dysphagia or inability to feed self, it does talk about provide alternative means of feeding. They might need an NG tube, temporary feeding. Sometimes if they think it's going to last a little bit longer, they'll go ahead and put in a gastrostomy tube because it's not as uncomfortable and it's very easy to take it out. So it's a temporary fix to get the patient nutrition. It can also be a long-term thing. But an NG tube is not comfortable for the patient. TPN might be ordered, and weigh weekly to assess the adequacy of the food intake. Also notice in that nursing care plan, and I'm going to talk about this before I move on, is impaired mobility related to weakness, paralysis, and poor balance. So in the intervention, you want to be sure that you position the limbs in functional alignment because they may not be able to move them. And perform range of motion exercises 3 times a day. So really important to do that range of motion. You know, how many times have you seen a patient with a stroke with a contracture of their arm? You can barely put that sleeve into a shirt, or their hand is constricted and closed up. Now remember, if that ever happens, the nails are still growing. So those nails can grow into the hand. It also is a breeding ground for yeast because it's an enclosed, moist area. So really, there's just no excuse for contracture if the nurses are doing their job. Okay, so nursing care in the acute phase. So you want to do an assessment. And that's the pre-hospital stroke scale on box 23.2. And it is a 3-step process to assess facial muscles, arm movement, and speech function. So it's the Cincinnati pre-hospital stroke scale. And it talks about the patient's asked to show teeth or smile so you can see if it's equal on both sides. The patient is asked to close both eyes or hold both arms straight out with palms up for 10 seconds. And the abnormal part of that is one arm goes down or does not move. The third thing is the patient is asked to repeat a simple phrase such as "you can't teach an old dog new tricks," and you see if they can repeat that without slurring or able to even use the right words. So you want to do a good health history and assess their risk factors. That's pretty important. So you want to ask what they've done before, what was their pre-stroke situation. You want to assess their motor function, their visual fields, ataxia, how they balance, how they move. Speech, language, cognition, do they understand what you're saying? And their motor and sensory abnormalities. Also, there's an NIH stroke scale, which is table 23.4. It's on the next page. And that standardizes and documents neurological assessments. So if you take a look at that, and what that does is like it has number 1 is level of consciousness, and then you look, 0 is alert, 1 is not alert, 2 is not alert, requires repeated stimulation to attend, and 3 is coma. So you go down each one of these 11 assessments, and then you grade them. So that standardizes and documents the neurological assessment. So everybody's essentially on the same page. All right. I mentioned here TPA just because it's important during this time. Is the patient getting better with that plasminogen? All right, on page 410 and 411, kind of goes back a little bit. But it talks about interventions in the acute phase. So, inadequate oxygenation. So closely monitor the respiratory status, because pneumonia, important to remember this, pneumonia is the #1 frequent cause of death due to aspiration. So you want to closely monitor the patient's respiratory status and be sure that there's a patent airway. That is a major priority. We want to prevent any injury, and again, because if they can't feel, we don't want them to get injured themselves. We also have to have safety precautions if they're confused. They might have sensory perceptual problems, so we need to keep an eye on that. They might be able to not have the good vision because of myopia or diplopia, or neglect. They might neglect one part of their body, totally forget about that. Oh, here's the rest of this. Yeah, okay. So elevated elevated body temperature. Again, that stress response can elevate their body temperature. A potential for impaired cognition, inability to communicate effectively. So be sure you have a way to communicate with your patient. Can be a board, could be a bell. And I want to go back here a minute to inadequate nutrition, because it's so important. So it is usually related to dysphagia, and they are unable to feed themselves. So we want to be sure that their body weight is maintained and they're getting adequate nutrition, because they may need TPN or even the bolus feeds. If we had to put them on the NG feeds or the G-tube feeds, we would need to give them nutrition through bolus feedings. And we need to maintain their body weight. That's a good criteria if they're getting enough nutrition. The elevated body temperature, as I said, the temperature regulating is in your brain, so that is affected. So sometimes you can have a fever, but you always want to assess for any underlying infection as well, like the pneumonia, or if they have a Foley catheter, we have to be sure we don't dismiss that. Potential for impaired cognition, inability to communicate, impaired mobility. So we want to be sure and do good transfers on their bed. Be sure we have watch their skin integrity, their joint mobility. We move them up and down, range of motion. Check their circulation. So we want to watch out for a DVT, because it is a major complication of immobility, especially in this patient population. So that passive and active range of motion will help keep that blood moving along so it does not stagnate and then produce a clot. Urinary incontinence and difficulty voiding. So it's not unusual for them to be incontinent after a stroke. They have what we call a flaccid bladder. We want to keep their skin dry so they don't have any skin breakdown. So you really want to keep an eye on that. Maybe a toileting schedule if they're able to get up, or offer the bedpan at frequent intervals. Constipation, loss of bowel control, that's usually related to immobility, dehydration, and some drug effects. But you do want to keep things going, because the immobility is going to lead them to constipation already. So we want to put them on stool softeners so that when they do pass their stool, it's soft. We don't want it to harden and cause them another problem. Inadequate coping is a situation Patient doesn't know, is this going to be a permanent situation? How is this going to affect my family? How am I going to get around? They're going to get very depressed. So that's something we have to encourage our patients to move. And depression is also seen after a stroke because of loss of brain chemicals. So maybe they need to be on an antidepressant. Maybe you need to get a counselor in. Altered family function. Well, I know that if it's a man, and it is more common in men, and there are usually the blood breadwinners. So if something happens to them, it's very difficult on the family. So it's an altered family function. I want to just go back up to the potential for fluid volume imbalance for a second, because this is repeating and hoping that you'll remember. So as I said, they're at a potential for fluid volume imbalance. So what is the symptoms of excess fluid? Bounding pulse, JVD, elevated blood pressure, crackles in their lungs, or edema. Now that's like across the line, that's going to be your sign of fluid volume excess. Deficiency, fluid volume deficiency, thready pulse, tachycardia, low BP, low urine output, or concentrated urine. So I want you to just commit those things to memory. They're really important. This is from your book, and it is a care plan, and with goals and outcome criteria and patient problems. I've got it in my book. In your book it looks a lot smaller, but I know you have it in your book, so you can look that over. But it just goes through the patient problems and what you can do to help them. So I just put that in there as a for you to remember to look at that. Has good information. All right, so what about interventions in the rehab phase? Inadequate self-care, this is the goal. Return the patient to prior level of functioning. That's really important to remember. Return the patient to prior level of functioning. And also encourage and allow the patient to do things for themselves. It may be slow, but you've got to encourage them and let them do it for themselves. It helps develop self-esteem, and it helps make them stronger as well. They do have a potential for injury due to that motor and deficiency, sensation problems, and vision impairment. Inadequate coping. After a stroke, a lot of time they're emotional labile. Their emotions are all over the place. And it's not just because they're depressed, they might cry a lot, but it also is just brain chemicals. Inability to communicate effectively, so they need encouragement, verbal cues, picture boards, develop a way of communication, very important. If they can write, that's fine. Inadequate nutrition, so what I mean here is reevaluation. So let's say they are getting bolus feeds or are on TPN. Well, at some point they need to be reevaluated, especially if they have dysphagia and they can't swallow. Well, maybe that's going to start coming back. So reevaluate. I had several patients where they're on tube, maybe medication given through the tube, but they're able to eat and have thickened liquids. So both things, it's like a transition where they have the tube and eat, and that's not unusual because they don't want to take the tube out too soon before they be sure that the patient can eat and get enough nutrition. And they might have to leave it in for that same reason. Impaired mobility. So use correct body mechanics when you move the patients. They are almost dead weight. A lot of times they can't put a lot of weight and stand up. So 2 people. Use a gait belt so that you don't hurt yourself, and you can have better control of the patient as well. Also, moving them from bed to wheelchair, be sure that you use good body mechanics. They might need to be put in a wheelchair. Get them out of the room. That's one thing. You need to improve their mental state. Get them out of the room. Take them for a walk. Take them outside to get some sun. And then constipation, inadequate fluid intake. They might not be able to swallow because of dysphagia. They also might just not think of drinking, or they might not be able to get a drink themselves. So you need to offer every couple hours some fluids. And then the patient should be on stool softeners. Impaired urinary elimination and functional urinary incontinence. It's not uncommon. So intermittent catheterization may continue to be necessary in the rehabilitation phase. Now, discharge. So before the patient goes home, they've been in rehab, getting stronger. They've been evaluated for physical therapy and other rehabilitation assessments. Goals have been set. Hopefully they've reached them. But things have to be ready at home. So you may need to put bars up and raise up the toilet. So home health will come in and evaluate your home to be sure that it's ready for the patient to be discharged to. And outpatient therapy is still an option for some patients. During and after the rehabilitation phase, patients and families need to be made aware of resources. There is daycare, there's home health that can come help, support groups. In rehabilitation, the patient is respectfully challenged to return to the highest level of function possible. So that's always our goal from the beginning of admission to discharge. We always want to get them to the highest level of function. Okay, thank you.